So I have the ultimate pleasure to introduce our speaker today. Dr. Brian Smedley has been gracious enough to join us to speak on healthcare equity. And so I wanted to give a little bit of a background about Dr. Smedley. For those of us here who may not be familiar with some of his work, but I can guarantee you that many of you are. Dr. Smedley is an equity scholar and senior fellow at the Urban Institute, which is not too far from us down in DC, where he conducts research and policy analysis to address structural and institutional forms of racism that impact the health and well-being of people of color. Formerly, Dr. Smedley was Chief of Psychology in the Public Interest at the American Psychological Association, the APA, where he led APA's efforts to apply the science and practice of psychology to the fundamental problems of human welfare and social justice. He is considered a national thought leader in the field of health equity and got his start in DC as an APA Congressional Science Fellow, and subsequently served at APA as Director of Public Interest Policy. Previously, Dr. Smedley was co-founder and executive director of the National Collaborative for Health Equity, which is a project that connects research, policy analysis, and communications, all of them with the on-the-ground activism to advance health equity. And he was also co-director of the Robert Wood Johnson Foundation Culture of Health Leadership National Program Center. There are so many accolades that are listed here that I won't go into every detail, but I will say that I've had the pleasure of meeting Dr. Smedley when I was on sabbatical at the Urban Institute, so I'm super excited to have him here to present to us this morning. So without further ado.
Well, good morning. Thank you so much, Dr. Tapp, for that kind introduction. Thanks, Dr. Diaz-Rue, for having me here. I feel a special connection to Drexel because I've worked with Drexel people for years, going back 20 years, and I didn't realize the depth of those relationships until a few years ago when I first came here to speak. And I've really enjoyed collaborating with Drexel students and faculty and scholars in the years since. So y'all are really lucky. You're in a great program, and what a tremendous environment to be in, what great faculty, what great colleagues you have. So I'm as excited for you as the work that we all do. So thank you so much for being here. I wanted to talk about an issue that has come up in recent years. Well, actually, it's been a long-standing public health problem, but a problem that's become even more acute in recent years, particularly since the Supreme Court's ruling in the Students for Fair Admissions decision back last summer. You'll recall that in that case, the Supreme Court ruled against Harvard University and the University of North Carolina for for the consideration of race in higher education admissions. They ruled that it is impermissible constitutionally for higher education institutions to consider race as part of an applicant's broad background qualifications, et cetera. So I want to talk a little bit about that and its relationship to healthcare and healthcare equity, an issue that we're all concerned about. But I hope to tie it to broader issues of racial justice and equity that we're all struggling with, particularly in this period of political backlash against the progress that we made in recent years prior to 2016. So I think you all are aware of what I'm referring to. It is this political environment that makes this work even more challenging today. And I had the pleasure of talking with Dr. Tapp and Dr. Diaz-Rue this morning about some of the issues and challenges that we face because we as researchers, I don't think have made that evidence as crystal clear and compelling as it needs to be to advance the case for DEI in healthcare settings and in public health broadly. I'm going to refer to a report that I had the great honor to be involved in 20 years ago at the Institute of Medicine. It's a report called Unequal Treatment. In 2003, the Institute of Medicine released this report, and so it drew a lot of attention 20 years ago, but unfortunately didn't move the needle. in terms of advancing healthcare equity. And I'm going to talk a little bit about the research that shows that we're not making tremendous progress. But importantly, we need to understand why we're not making progress and what tools are at our disposal and what areas of research are necessary to better inform policy going forward so that we have a much more equitable space, much more equitable climate in which we can deliver and finance healthcare. So I'm going to refer to the unequal treatment report, but just to note that we are in a period that offers both great promise and peril. You all know that there are dozens of public health departments around the country that in 2020 and 2021 began to communicate to the public that just as a viral epidemic is a public health crisis, racism is a public health crisis. So this was an important development to see, and we're all aware of the fact that there have been many important and powerful statements about racism as a phenomenon that we need to directly tackle if we're going to advance healthcare equity. My sense has been that those have largely been statements and not backed up by the kinds of policies and structural change that we need to fully eradicate racism in all of its forms. And again, not just in healthcare, but also in public health, as you all are well aware. So importantly, we see growing awareness and recognition. We also see a growing backlash to this notion that racism continues to be a force in this country. You all study racism and its relationship to public health. So you all know that racism is not just an individual phenomenon. It's not just a question of a few bad apples out there who harbor racial animus. In fact, we have many, many individuals who arguably are infected at the interpersonal level with racist ideology and racist beliefs. Most folks, if you've been socializing in the United States, subtly or unsubtly, have been raised in a society that preserves a notion of human hierarchy and the value assigned to what we socially call race. So we get interpersonal racism. We get that that happens. But of course, as public health professionals and researchers, we're primarily concerned about other forms of racism. The interpersonal forms are clear. They directly and indirectly confer risks for poor health. We know that individuals that face instances of discrimination gradually face an erosion of health and additional stressors due to racism. But at a structural level, we see racism operating, of course, in the United States. We see structural forms of racism where collectively we have social structures that produce cumulative, durable race-based inequalities. And so one of the major mechanisms at a structural level, of course, is the phenomenon of residential segregation, which is a subject of study for many scholars here, including Dr. Tabb. Residential segregation is important because if you look at our history, of course, we have been deliberately sorted into separate spaces, not only in terms of residential spaces, separate workspaces, separate educational spaces. And this, of course, was enforced by law prior to 1964 and enforced by custom and practice since then. So we see many instances of deliberate efforts to enforce separation of racial groups, but structural racism most directly tied to residential and school segregation, work segregation. These separate spaces confer risks directly and indirectly for poor health for people of color and other marginalized groups. So I want to talk about forms of structural racism and particularly how they show up in our healthcare systems, often in ways that we don't recognize because we see this on a daily basis and in effect have blinders on in many cases to the persistence of structural racism. Institutional forms of racism refers to policies and practices set up by institutions that are often neutral with respect to race on their face. Very few of the institutional forms of racism explicitly say we need to discriminate against people of color, but rather these are policies and practices that result in racial inequality regardless of the intent of those who have created those policies. So for example, when we look at law enforcement practices, all of us are familiar with the practice of so-called stop and frisk, right? It originated in New York City, where police officers would routinely stop people without necessarily any suspicion of any illegal activity, would ask questions, would search in many cases. In New York City, well over 90% of the instances when individuals were stopped were Black and brown young men. So clearly, this is a policy that disproportionately affects that population. And of course, contact with law enforcement can often escalate and result in worse outcomes than just being stopped and frisked. So the stop and frisk policy was facially neutral with respect to race, but had a disproportionate and negative impact on communities of color. I mentioned individually mediated racism. We're all aware of that phenomenon. I think that the levels of racist ideology and thinking in our country are vastly underestimated, which in part fuels the backlash that we're seeing today to progressive policies. And then there are our internalized forms of racism, which we're all vulnerable to, but particularly for racially marginalized populations, racialized populations, the belief in one's inferiority can lead to vulnerability psychologically in terms of physical health. And those stereotypes have been shown to actually harm the performance, for example, of students of color in academic settings. The psychologist Claude Steele studied what he called stereotype threat. The suppression of academic performance based on the fear of conforming to broadly held social stereotypes about different population groups. So these forms of racism operate at different levels, but cumulatively they confer risk for poor health for people of color. And it's been my belief that if we attempt to tackle just one form of racism, we're not going to fully eradicate racism. Just like a balloon that you might squeeze at one end, it's going to just expand at the other end. So clearly we need comprehensive strategies that will tackle racism operating at multiple levels if we're serious about these issues. One example of the ways in which racism operates at multiple levels can be found in our healthcare systems. We know that there are deep racial and ethnic disparities across a range of systems, public, private, federally qualified health centers, other types of clinical settings. But we know that in settings that are characterized by time pressure on providers, resource constraints, so that physicians and nurses cannot order all of the diagnostic tests that they might like to order in order to fully understand a patient's presenting concerns, and cognitive complexity. Patients presenting with complex medical problems that are often a lifetime accumulation of poor health and stress. All of these problems increase the likelihood that providers are going to fall back on stereotypes and biases to fill in missing information, even if they are not overtly biased themselves. And this is a natural byproduct of the way that human beings think. We tend to categorize people and things and phenomena so that we can simplify the world and be able to better understand the world. I'm going to say more about the psychological research underlying this understanding of how difference related to race, gender, age, any number of other factors can affect our thinking and our behavior, because that's the way that our minds naturally work. And in the case of physicians working in settings characterized by time pressure, resource constraints, and cognitive complexity, those conditions are more likely to elicit stereotypes and biases among providers. Unfortunately, those very kinds of characteristics of healthcare institutions, time pressure, resource constraints, and cognitive complexity, are more likely to occur in our so-called safety net institutions, where a disproportionate share of patients of color are seen. So the very conditions in which patients of color are seen are more likely to even elicit the kinds of stereotypes and biases that we know may infect the clinical encounter in negative ways. So the Unequal Treatment Report, published in 2003, caused quite a splash at that time. Surprisingly, surprised me, because people who study racism know it infects every system, every aspect of American life. But for the American public to be confronted with evidence that biases and stereotypes on the part of providers, or structural factors such as differences, such as the ways in which healthcare is financed and delivered, all of those factors contribute to racial and ethnic disparities in the quality of care. But At that time, that was shocking for many people to hear, particularly among health professionals. When this report was released, we heard from a lot of provider groups saying, how dare you accuse us of biases and stereotypes? How dare you accuse us of being unfair to these patients? We're all highly trained, dedicated professionals. You absolutely are. I've not met a doctor who wants to consciously provide a lower quality of care to a patient of color. But all of these forces, implicit biases, unconscious biases and stereotypes, and characteristics of the kinds of healthcare systems in which patients are seen may contribute to these inequities. And we have to make providers aware of these inequities and not let people off of the hook for providing more equitable care. So fast forward to today from 2003. Have we made progress toward eliminating racial and ethnic healthcare disparities? So mind you, in 2003, this report caused shockwaves across academic medical centers, medical schools, nursing schools, dental schools, and all of those health professions. So awareness of these inequities has increased, but yet we've not made progress toward eliminating the gap in access to quality of care and outcomes of care, even despite passage of the Affordable Care Act. We've made a lot of progress, and I want to point to some of that progress. But the reality, according to the Federal Agency for Healthcare Research and Quality, is that we've made little progress since 2000 in narrowing these healthcare inequities. So according to their measures, these disparities have narrowed for only about 8% of measures for American Indian and Alaska Native populations relative to the white population, 2% of measures for Asian populations, 3% of measures for Black populations, et cetera. You get the picture. There's very little progress overall, even as the quality of healthcare in America has improved overall. That gap remains. Again, looking at the Agency for Healthcare Research and Quality's assessment of this problem, if you look at their 2021 annual National Healthcare Quality and Disparities Report, they find that relative to the white population, for several populations of color, including American Indians, Alaska Natives, Asian Americans, Black Americans, Native Hawaiians and Pacific Islanders, and the Latinx population, as you can see here from this slide, the share of the quality measures that ARC uses, the red indicates where worst quality persists, the yellow indicates where these two racial groups are receiving about the same quality of care, and green indicates where populations of color are receiving a better quality of care relative to the white population. And overwhelmingly, we see that we are either stagnant, not making progress, or that along some of these measures, things are getting worse for many populations of color relative to the white population. And so this is comparing these populations in recent data years. When we look over time, say, for example, from 2000 to 2019, just looking at the trends in quality of care for the African-American population, we can see that, again, that on most measures, we are seeing either no change or a worsening of those inequities in care relative to the white population over time. So again, despite the awareness of these inequities, we are not making tremendous progress toward their elimination. Why does this matter? Unfortunately, these disparities in access and quality are often associated with poorer outcomes for patients of color. And there are many, many examples of these inequities. At the time that the Institute of Medicine was doing the unequal treatment study, we reviewed volumes of literature. There were some 600 papers that we reviewed across a range of clinical services, across a range of disease areas. These racial and ethnic disparities remain persistent, importantly, even after we control for differences in insurance status or income to pay for out-of-pocket costs. So, for example, patients of color are less likely than white patients to receive preventive care and even routine medical procedures. Black patients are treated less for pain than white patients. A number of studies have shown that when patients enter an emergency room with a long bone fracture, that white patients on average get more intensive pain treatment than patients of color, even with the same long bone fracture. Presumably, they're both painful. And yet patients of color receive lower quality care. Same for sickle cell patients who are in severe pain. They wait longer in emergency rooms to get pain medication than white patients with a similar painful disease. And you can see how stereotypes are beginning to play into some of these quality disparities because of the fear on the part of some clinicians that these patients of color might be more dependent on pain-killing drugs or may become more dependent. Black patients are less likely than white patients to receive kidney transplants. Doctors are almost twice as likely to refer white patients to a specialist than they are to refer Black patients. And again, that's across a range of specialty services. Black and Latinx individuals are less likely to receive appropriate cardiac medication or to undergo cardiac bypass surgery than white patients. So at the time that we did the unequal treatment study, we looked across a range of disease areas from A to Z. So starting with A, asthma, arthritis, cancer, diabetes, same picture in terms of the research. These racial and ethnic disparities persist in access, quality, and outcomes of care. So why do these persist? We have this high level of awareness in the health professions community. We have high levels of awareness of the problem of racial and ethnic disparities in our medical schools, nursing schools. I believe that there are many dedicated individuals who are sincerely trying to address this issue, but there are factors that continue to pose barriers. There are many, many factors that pose barriers, but personally, I think that there are at least 5 issues where we can make progress toward moving that needle. The first is a structural problem. We have the persistence of separate and inequitable care for patients of color relative to white patients. This is due to many factors, residential segregation being one, the maldistribution of healthcare resources, which flows from the way that we finance care. We have deeply inequitable financing across different geographies, different population groups, rather than a single financing system that would provide equitable funding for all the care that folks may need. Healthcare system policies, such as limited provider networks, may also contribute to the separation of people of color into separate hospital spaces. There's a recent powerful essay by Dr. Uchi Blackstock, and some of you may have seen this, where she talks about the 2 hospitals in New York City, New York University and Bellevue. These 2 hospitals are separated by a wall. Bellevue is where the uninsured and underinsured patients are disproportionately seen. People of color, people with low incomes. NYU is the private pay patients, wealthier, whiter. The better quality of care happens at NYU. And yet, these 2 hospitals are separated by a wall. Again, it relates to how we finance care. It relates to geography. I would also argue that it relates to the trustworthiness or lack of it among some of the institutions in communities of color that serve those institutions. So where there is a lack of trust, obviously, some patients are going to avoid some of those systems to the extent that they have a choice. Many people in the United States do not have a choice where they get their care. We also have the problem of tiered health insurance and differences in provider reimbursement. So importantly, we have the Affordable Care Act, which expanded access to both private forms of insurance, where people went to their state marketplace or the federal marketplace, purchase insurance, or expansions of Medicaid and other public sources of insurance, a child insurance program, for example. But these are not the same insurance products. We all know that, right? And in fact, many medical ethicists have argued that the low reimbursement rates associated with Medicaid are themselves a racialized form of inequity that will persist because politically there is less support for trying to expand Medicaid so that providers are reimbursed at the same rates as Medicare providers. So that very problem of tiered insurance, some forms of insurance are better quality than others. And in most studies that look at whether or not patients are insured, they do not note the form of insurance. They just note whether the patient is insured or not. So there are vast differences. And of course, people of color are clustered into lower tier insurance products and plans for economic reasons and other reasons. Clinician biases, stereotypes, and prejudice remains another area where we're not making as much progress as we could. By this time, most providers serving today have been exposed to curriculum around biases and stereotypes, but we still see these biases persisting. How can we begin to address these problems and train our providers better so that we can better serve a diverse patient population. So I'll say more about that in a second. Race-based clinical decision supports and algorithms. It's surprising today how much clinicians still rely on race-based clinical decision supports and algorithms. In other words, the assumption that there's something biological or genetic about racial differences that would justify different treatments and different clinical decisions. These kinds of decision supports may reinforce those antiquated notions of race as being somehow biological or genetic. And the reality is there's no research to support the notion that we should be making different clinical decisions based on a person's race alone. We have to take so many other factors into account. Finally, the persistent lack of diversity among healthcare professionals remains a problem. And I'm going to talk about some of the recent research that shows the importance, the value of provider diversity, and in particular, racial concordance between patients and providers, particularly for African-American patients, that is beginning to show that concordance has great value. Not to suggest that as a policy, we should be trying to match patients and providers on race in every instance. That would leave patients of color at a tremendous disadvantage given the lack of diversity in our healthcare systems. Rather, we have to better prepare our entire workforce, regardless of the race or ethnicity of those providers, to serve diverse patient populations. So I want to dig into each of these 5 issues in a little bit more detail, and then I'll conclude, and I'll be happy to have a dialogue and to address questions that folks may have. Let's talk first about what some have called medical apartheid, separate and inequitable care for patients of color relative to white patients. My colleague at the Urban Institute, Anuj Gangopadhyay, and his colleagues looked at this question, studying differences in Black and white patient safety measures using discharge records from 27 states. So looking at whether folks had to be readmitted for infections or other kinds of patient safety problems. This study found that Black patients experienced higher rates of adverse patient safety events on 55% of patient safety measures. That's astounding, right? When we have a goal of having 0 adverse events. For over 80% of patient safety indicators, Black patients were significantly less likely to be admitted into hospitals classified as high-quality hospitals. This is part of where we begin to see medical apartheid beginning to play a role, because Black patients, for a variety of reasons, are less likely to be referred to and admitted into these high-quality hospitals, the grade A hospitals, according to Leapfrog Group. And these are, of course, the hospitals that are best at minimizing patient safety risks. So this segregation of patients, in part, helps to explain differences in the quality of care and outcomes. The same research team found that Black patients experience higher rates of hospital-acquired illnesses related to surgical procedures relative to white patients treated in the same hospital. So we have evidence of disparities in the quality of care across hospitals and hospital systems, but we even have evidence of higher rates of patient safety problems for Black patients, even relative to white patients treated in the same hospital. So these within hospital differences remain even when comparing Black and white patients with similar coverage types. So again, these are among the kinds of structural problems that we would expect to see with the persistence of segregated healthcare. Segregated care, of course, is also tied to this problem of tiered health insurance. This is why an NYU can treat very well-insured patients, whereas Bellevue, right next door, cannot provide that same quality of care. The Unequal Treatment Report noted something that I think remains a problem to this day. It was not solved by the Affordable Care Act when they noted that medical care financing arrangements should discourage fragmentation of healthcare provision into separate tiers of providers who adhere to different standards of care. In other words, money makes a difference in the quality of care that these providers are providing. We know that Medicaid and other government programs that mandate enrollment of beneficiaries in managed care should be prepared to pay plans at rates that will give Medicaid enrollees access to the same health plan products, serving substantial proportions of privately insured patients. That was written 20 years ago, and this problem remains today. Again, a structural problem that is deeply associated with race. I'd like to now just spend a few minutes talking about racial biases and the fact that all of us are vulnerable to racial biases as a way of setting the context for understanding why physicians and other healthcare providers are vulnerable to these biases, but then more importantly, what do we do about it? I want to say at the outset, this is not an excuse for any of us to fall back on biases and stereotypes, but the reality is often we submit to biases and stereotypes every day that we're not fully aware of. We're cognitive misers. We don't want to expend a lot of intellectual energy if we don't have to. We limit the effort we expend while maximizing our presumed understanding of the world by relying on mental shortcuts. And that's where the tendency to categorize and to generalize about people, populations, and events based on that categorization. Social categorization makes people feel like they understand the world better because they feel like they can better predict how a person might respond to an interaction. And they feel that they can see members of outgroups as being alike, again, as a way to try to understand phenomena. But in the US, the most prominent form of social categorization is race. Race is often the first thing you see, even if you believe you are colorblind. We know from extensive psychological research that people cannot ignore race, particularly if you've been socialized in a society like the United States, where race is so socially significant. It has been one of the most socially significant ways to categorize people, first by law, now by practice and custom. It is our habit to notice race and to make generalizations about people based on that observation. Implicit biases are those that are automatically and very quickly activated when people are exposed to difference. So if I'm interacting with someone who is a different gender, a different race, a different age, from a different socioeconomic background, from a different part of the world, I may automatically have stereotypes and biases coming into my head that I may not be consciously aware of. These implicit attitudes and stereotypes reflect feelings and thoughts about a target group that are part of a person's culture. So in the United States, of course, we have deeply, deeply ingrained stereotypes about a variety of different groups, not just related to race and ethnicity. But as we become socialized in our culture, these feelings and beliefs become so ingrained that they automatically produce associations between a specific target and the characteristics that we stereotype people with. Stereotypes of this nature are so well learned that people are often unaware that they're making these stereotypes. We know that racial biases are present among healthcare providers, just as they are in the general population. A systematic review of 15 studies measuring implicit bias confirmed that health professionals hold the same level of implicit bias against Black, Latinx, and dark-skinned people as the general population. They found that implicit bias was significantly related to patient-provider interactions, treatment decisions, treatment adherence, and patient outcomes. And that was a study from nearly 10 years ago. Another systematic review of 37 studies confirms substantial evidence of pro-white or light-skinned, anti-Black, Hispanic, American Indian, or dark-skinned bias among professionals at a variety of levels and across a range of disciplines. So these biases exist in the provider population. Importantly, they're also related to poor outcomes for patients of color. One study that continues to stun me to this day, in 2017, Hoffman and colleagues found that over 70% of white medical students believe that there are biological differences in pain perception between Blacks and whites. You'll recall that earlier study that I cited that showed differences in treatment. Again, likely based on stereotypes of pain perception. Hard to imagine that in 2017, medical students still believe there are differences in pain perception. But more recently, we've seen other work that is specifically related to clinical decisions. So Alex Green and colleagues in an experimental study presented physicians with a series of patient clinical vignettes. Prior to exposing these providers to these clinical vignettes, these investigators measured the level of implicit and explicit bias among these providers. Explicit biases are relatively easy to measure. There's obviously often a response bias. People don't want to reveal their biases. But unlike explicit biases, implicit biases can be measured even with your awareness of what the investigator is trying to do. How many of you have taken the implicit association test? Okay, so you're familiar with the implicit association test. This is a test that's hard to fool. You know that it's measuring the speed with which you can make an association between a marginalized or stereotyped group and a positive or negative word, right? So when you take the implicit association test in the race condition, you are shown in some versions of the IAT an African-American face and a white face. And you're asked to quickly make an association between a positive or negative word. For the vast majority of people who take the IAT, it's easier to make an association between a positive word and a white face much more quickly than the reverse, to make an association between a positive word and an African-American face. Conversely, most people who take this test much more quickly and automatically make an association between a negative word and an African-American face. The test is obviously much more complex than that. And there are other conditions that you can look at. You can look at gender. You can look at BMI. You can look at perceived sexual orientation or gender identity and still find implicit biases associated with the outgroup. And so Green and colleagues measured the level of implicit bias among this set of providers, then presented a clinical case vignette where in each case, the patient, an actor, needed thrombolysis for myocardial infarction. What the study found is that as implicit biases increased among the providers in their study, the likelihood of treating Black patients with thrombolysis decreased, right? So this can be, again, this is an experimental study, but were this a real life patient that could make a difference in terms of survival or not for that patient? Another study published much more recently looked at the relationship between patient descriptors in electronic medical records and racial bias. So these researchers looked at a sample of over 40,000 medical records from nearly 19,000 patients, and they looked at the descriptors of those patients in the medical record. They sought to determine if they could find at least one negative or derogatory statement in that record, and if there were racial differences in the use of those derogatory descriptors. What they found is that African-American patients had over 2.5 times the likelihood of having negative descriptors in their history and physical notes relative to white patients. The authors write that our findings raise concerns about stigmatizing language in the electronic record and its potential to exacerbate racial and ethnic health disparities. As you all know, those records don't just stay with that one provider. They could be shared broadly. And you can imagine the negative valence that a provider may have about a patient of color seeing those kinds of negative descriptors in the record. And you can see how that might snowball into progressively worse care for those patients. Some more recent research shows that provider diversity and in particular, racial and ethnic concordance, particularly for Black patients, could make a tremendous difference in terms of outcomes. You all know that Black newborns have 3 times the mortality rate of white newborns in the United States. Greenwood and colleagues examined 1.8 million hospital births in Florida over the last couple of decades and found that when Black birthing people are attended to by Black OBGYNs, mortality rates were significantly reduced, particularly in high-risk pregnancies. So those benefits of that racial concordance increased during more challenging births and in hospitals that delivered more babies. So high-risk Black pregnancies, outcomes are better when the delivering doc is African-American. A more recent study finds that as the representation of African-Americans in the primary care physician workforce increases, Black mortality decreases at the county level. These investigators found that on average, for every 10% increase in county level Black primary care provider representation was associated with a 1 month higher life expectancy among Black patients. Higher Black primary care provider representation was also associated with lower all-cause mortality and found reduced disparity mortality rates between Black and white individuals with higher Black PCP representation. These studies need to be replicated with great care. There are obviously potential confounding factors. Those counties that have a higher representation of Black primary care providers might be better places for Black people to live on average anyway. But we need to do more to understand this finding because it suggests that there are both clinical and potential population level benefits. The use of clinical decision supports. I'm not going to say too much about this. Many of you are aware of the fact that clinical decision supports, which include forms of machine learning, clinical algorithms, are being increasingly used in our healthcare systems to predict outcomes and to improve the quality of care. But the potential of these tools to advance equity is complicated by the reality that the data going into these models are often tainted with racism, because we know that patients of color are coming into clinical care with often a higher burden of disease and poorer outcomes. That prompted the New England Journal to write in 2020 that, quote, many of these race-adjusted algorithms guide decisions in ways that may direct more attention and resources to white patients than to members of racial and ethnic minorities. So clearly the use of clinical algorithms is important, but these differences that we see may be due to the effects of racism and other determinants of health, not to a priori biological or genetic differences between different racial groups. In other words, racism over the course of the lifespan is likely complicating these algorithms because of the impact of racism to deteriorate health across the life cycle, and that is not being accounted for in these algorithms. I was really honored to work with my fellow psychologists, Lou Pinner, Jack DeVideo, who's one of the leading scholars around implicit bias, now Hajiwara, to write the book Unequal Health, Anti-Black Racism and the Threat to American Health, where essentially we argue that racism has posed a threat to every American's health for many reasons, including the fact that racism complicates our ability to advance policies that would benefit everybody. And we are living through such a time right now where there is broad disapproval, opposition to public policies that are perceived as being helping people of color. We dive into some of this research in this book, and we talk about some broad remedies, such as trying to address structural inequities by promoting universal coverage with comprehensive benefits and equitable reimbursement. If we had a Medicare for all health financing system in this country, every healthcare institution would receive an appropriate reimbursement for services provided regardless of the race or ethnicity of the patient population. In that way, it would infuse needed resources into poorly resourced systems where people of color are overwhelmingly being seen and are disproportionately seen. So a universal coverage and universal healthcare financing system would address the maldistribution of healthcare resources and some of the medical segregation that we see. So for example, it is clear that our best healthcare resources go to wealthy and whiter neighborhoods. That's the way markets work, right? And that's the way our healthcare system, based on that market fundamentalism, tends to work. But a universal system would direct resources more equitably where they're needed. It would not completely eliminate racial and ethnic health inequities. We know from countries that have universal healthcare systems, such as the UK, that racial and ethnic differences persist. Why is that? Because despite the fact that we are financing care in ways that are more equitable, we still have biases in our healthcare systems, both structural and at the individual level. We still have racism operating across the lifespan to create a burden of disease and illness even before people come into our healthcare systems. And that's true in the UK and other countries that have universal healthcare systems. Such a system would, however, go a long way toward creating a much more equitable foundation for healthcare financing and delivery. We need institutional equity. We need to provide resources according to need. That's the very definition of equity, right? And we need to not inadvertently disadvantage under-resourced healthcare systems. So in today's pay-for-performance incentive programs, for example, we are intentionally or unintentionally rewarding those systems that are already well-resourced, that already have the capacity to more equitably treat patients. Those systems that are deeply under-resourced, again, remain the systems where people of color are disproportionately seen. So we've got to ensure institutional equity. And one of the best ways, I think, to ensure that is public accountability. We need to publicly report healthcare quality and access by patient demographic factors. And so those data are being collected, but they're not being collected in a comprehensive fashion or in a systematic way that would provide the same information to consumers. I think that if at the health system level or the hospital level or at the clinic level, if public reporting of healthcare access and quality metrics was required, you would see a vast change and an improvement in access and quality of care for patients of color, because that which gets measured gets changed and that which gets reported out gets paid attention to. And so the lack of such a reporting system helps to contribute to a stagnant progress toward equity. Clinical equity. We need to stop the inappropriate use of patient race in medical diagnoses and treatments. Clearly, race is not predictive of outcomes for clinical services, and so we need to be treating patients with the understanding of their own individual history and backgrounds. Also, clinical equity, it means addressing race and difference in the clinical encounter, improving our ability to train providers around bias, and importantly, how to understand the relationship between bias and behavior. My colleague Jack DeVideo argues part of the problem with bias training, anti-bias training, is that somehow we think we can remove biases. It is very hard to remove biases, particularly if you've been socialized in a country like the United States or many other Western nations where there is a deep-seated, unstated belief in human hierarchy. We are unable to completely remove those biases, particularly those implicit biases that have accumulated over a lifetime. What Dr. DeVideo argues is, I can't stop those biased attitudes and thoughts from coming into your head, but I can disrupt the link between those thoughts and your behavior as a clinician. And so I believe that part of what we've got to contend with is the fact that bias management, bias training to date hasn't focused on behavior. It's focused much more on the thoughts, feelings, and attitudes of providers that are very difficult to change. On the other hand, we can change behavior, particularly if we have the appropriate incentives and disincentives to do so. Finally, educational equity is clearly at the foundation of many of the inequities that we see. So the fact that students of color are disproportionately seen in, again, under-resourced schools that are poorly prepared to help young people prepare for higher education and beyond, these deep educational inequities, I fear, are getting worse. We now have evidence that we are moving more toward the levels of school segregation that we had prior to the 1954 Brown versus Board of Education decision. So obviously, that decision lacked the political will to enforce it. We saw deep, massive resistance, not just in the South, but all over the United States to segregation. And the segregationists ultimately, at least to date, have won, because well over half of kids of color are in majority minority schools, deeply under-resourced, fewer courses to help prepare people for higher education. In schools serving kids of color, do we have advanced placement coursework? Do we have teachers credentialed to teach in the subjects that they're teaching? We do not. That's much more likely to happen in wealthier, wider suburban school districts. So until we advance educational equity, it's going to be hard to advance workforce equity and workforce diversity. Plus, we also know that education is one of the most important predictors of your health status. If you've achieved high levels of education, your health on average is going to be much better. If we consign kids of color to poorly performing schools, then we are constraining not only their economic and educational opportunities, we're also assigning them to a lifetime of poor health. So on this issue of racial and ethnic diversity in 2021, according to the Agency for Healthcare Research and Quality, we still had a massive inequity in terms of the racial and ethnic distribution of the healthcare workforce relative to the US population, which you see here. So for example, 64% of our health professions workforce are white providers, and that population is only about 60% of the US population. We have a tremendous dearth of African American and Native American providers and Latinx providers relative to their proportions in the population. In 2005, the Institute of Medicine published another report focused specifically on this issue of workforce diversity. This report was called In the Nation's Compelling Interest. And the focus of this study was on what can health profession schools do to ensure greater diversity among faculty, students, and the subsequent healthcare workforce. This obviously was published many years before the Students for Fair Admissions decision, but many of the recommendations still hold because the Supreme Court did not say that you could not look at a whole file review. It did not say that you could not consider a student's personal or family background and the role that race or ethnicity played in getting that student to where they are today. So this report, I believe, is still relevant, even with the Students for Fair Admissions decision, because it talked about the need for changes in education admissions, including whole file review and de-emphasizing standardized test scores. You all know that the MCAT does not predict how you perform as a physician. In fact, it's a poor performer of how you predict how you perform as a physician. It predicts very well how you'll perform in your first 2 years of medical school. But personally, I don't want somebody who hates the MCAT but has poor interpersonal skills or poor listening skills. So clearly, we need to look at all of the factors that make a successful provider who is prepared to serve a diverse patient population. So it's one thing to try to attract and recruit diverse faculty and students. We've got to attend to the institutional racial climate. In too many instances, there are institutions that purport to value diversity, they attract diverse students and faculty, but the climate itself remains hostile to diversity. And these are some of the very institutions that are beginning to backslide around diversity, equity, and inclusion commitments in this current political environment of intimidation. We have to attend to diversity efforts and accreditation standards. It's encouraging to see that the Joint Center is beginning to adopt some recommendations around the importance of diversity, but we need robust diversity efforts and accreditation standards. For too long, we've allowed opponents of diversity to equate diversity with a lack of quality. These accreditation standards, if implemented properly, would reinforce the notion that diversity, equity, and quality go hand in hand, particularly in a health professions context. Fourth, financial barriers. You're all well aware of the financial barriers that pose obstacles, particularly for lower income students to enter into health professions careers. But yet we have effective mechanisms that are vastly underfunded that could address the financial needs of these students while ensuring that they are serving in areas that need providers in those communities. So our federal health professions programs have been very successful in addressing the financial needs of students in medical schools, dental schools, et cetera. And in return for a service agreement serving X number of years in a medically underserved community, these providers are able to provide services and increase the healthcare infrastructure while having their educational expenses addressed through the federal government. A very important program that, in my view, needs to be expanded dramatically so that we can get more providers into underserved communities. And then finally, as I noted, educational equity. Ensuring that all schools have the resources to get their students into higher education and beyond, instead of being vastly underfunded in ways that are too often corresponding and correlating with race. If a school is a predominantly kids of color school, that school is not likely to have the resources, the teachers, the kinds of assets and attributes that you need to help these students advance in their careers. Let me just conclude with a quote from someone whom I admire, Dr. Mary Bassett, former Commissioner of Health in New York City. She wrote a few years ago in an article called "We Must Name Racism as a Cause of Poor Health." She wrote that anti-racism is a collective healing without which our nation will remain painfully and inequitably divided, corroding opportunity, spirits, and bodies alike. So the implications of inequity for our country are deep and profound. And Dr. Bassett, I believe, is quite correct that in order to promote healing broadly, we have to confront racism and the ways that racism shows up in our policies, practices, and healthcare systems. I thank you so much for your time and attention. I hope I haven't spoken too long because I would love to interact with you all and take comments or questions. So thank you so much.
So why don't we take some questions here in the audience? I know that there's one online, but are there any questions in the room for Dr. Smedley? Yes.
I have so many questions, but thank you for a great, I came in a little late, we apologize. I'm actually a city council member for the city of Philadelphia and public health. I am the chair of public health committee. So I'm very interested in what you presented, but more interested in how our city responds to this, right? And so a couple of questions. One is, you talked about, the elephant is in the room, it's racism, the outcome is, that's impacting outcome. I'm looking at maternal mortality very specifically. And so we know this, and we know the clinical bias is embedded. How do we actually address it outside of the insurance and all of that? How do we actually hold accountable our hospitals and physicians and then have a consequence for that in order for that behavior to change? I don't know how you, so I'm looking at it from a legislative perspective. What can we do that will create better outcomes for our residents in Philadelphia?
Sure. Thank you so much for that question, and thank you for your commitment to justice and equity. So when it comes to infant mortality and maternal mortality, I'd argue that the place we got to start is well before conception, And in fact, creating healthy environments for young women who might themselves become mothers at some point. That includes things like investing in early childhood education, investing in nurse home visitation programs to ensure that the home is safe, to ensure that kids have what they need, to ensure that parents and families have what they need. The nurse home visitation program has proven to be cost effective in terms of addressing a range of potential poor health outcomes down the road. So attending to the needs of people who are potentially birthing people well before conception is so critically important to ensure proper health. And then you mentioned one of the solutions, which I believe is accountability. We got to publicly report the birthing outcomes of our hospitals, clinics. I realize that there are lots of complications there. People have been challenged with trying to collect consistent data, but you can imagine the power of being able to report out on the birth outcomes of different hospitals in this city. Which ones have evidence of more equitable outcomes? And that has to be assessed up to 1 year, 3 years after birth, because we know that in many cases, the risks may come well after birth. And so we have to be able to provide support to new parents, nurse home visitation programs. I would argue that helping families to access the resources that they need well outside of healthcare is critically important. So we know, for example, that as a result of residential segregation, many people of color are in concentrated poverty neighborhoods that contain a host of health risks, environmental health risks in terms of the retail food environment, health risks in terms of what's present in the neighborhood. Attending to all of those factors is so important. So I'm arguing for comprehensive strategies because we cannot solve the infant mortality problem through simple solutions. We've got to be attending to the community context. We have to attend to the life course and to help our future birthing people to be as healthy as possible prior to conception. Thank you for your question.
So I know that online there are 2 potential questions in the chat. Do you want to just unmute and ask your question?
Yes, hi. This is Francesca Muchacho. I'm a student, PhD student at Drexel. So I just wanted to say thank you so much for this great presentation that I thought was just so elegant and brought together so much evidence so well. My question is about influencing political will. So I agree that at all levels, we're living in really tough times, have a lot of polarization, political division, and just overall lack of will to address structural racism at all levels. And I'm just curious, and I know that your institute does some work with decision makers. And so what can some of the messaging to legislators and other decision makers at the local, state, and federal level entail? I actually used to work in policy and federal government, so I know that science communication is crucial and making it as clear and accessible as possible is crucial, but sometimes that really doesn't seem to be enough. We can bring all this evidence and it for whatever reason, it doesn't seem to be enough. So I was just wondering if you had any thoughts on other strategies to change hearts and minds when there's so much resistance. Thank you.
Oh, such a great question. Thank you for that. We are in a challenging time. Everybody knows that. What I think we need to be mindful of is that over the long course of history, what we're experiencing now is entirely predictable. We're coming out of a period of relatively progressive policy change, and we are experiencing the backlash to that policy change. So let's situate this in its historical context. There is great value in independent research that you all do, that we do at the Urban Institute. But too often we produce this research in a vacuum, as if we're the only ones that are asking appropriate research questions. We've got to be much more strategically aligned with grassroots movements and advocacy movements on the ground. I don't think that we've had enough conversations with our major national civil rights organizations, NAACP, Urban League, Unidos US, National Congress of American Indians. We need to be in conversation with these groups to understand what is your policy agenda and how can we support that agenda? How can we be aligned strategically? And this is not to suggest that we contort our research to fit an advocacy agenda, but rather to be informed by what the advocates are demanding and vice versa, to conduct research that can inform their policy demands. We can't work in a vacuum. We need to be in partnership with those forces that are working to counter this current moment. It's just that, it's a current moment. We have opportunities to advance an equity agenda in a more favorable political climate. I'm encouraged by the fact that young people don't buy into the kinds of rhetoric we're hearing from the right today. There will be an era when today's young people are tomorrow's leaders. And so we need to be prepared for that moment when we can advance more progressive policies that are based on evidence and based on science by doing that research now. So I think to address political will, we need to stop being shy about getting into the mix of understanding how policy is changed. No policy was ever changed by an article published in one of our journals. I don't think. Maybe you can point to one that I don't know of. Policy change has always been accompanied by grassroots movements working together with faith leaders, civic institutions, researchers. And so I'm eager to forge those kinds of alliances because let's be honest, that's what our opponents have done for years with a very strategic eye toward the long game and the kinds of outcomes that they've been seeking. We see it in example after example of how the right has overturned policies that we know promote health and well-being because of a narrow ideological agenda. So evidence alone is not going to change that. We're not going to change the fear and loathing of that some of our elected leaders have tried to foment, not by itself, but our research can help to change the narratives and the policy demands of folks who are pressing up against those elected leaders. So I thank you for that question. That's one I think about every day.
Thank you for that answer. That's very actionable, if difficult.
Thank you so much. So why don't we give our speaker a round of applause?